in pediatric. So our lecture starts today with talking about initiating an ECMO program, what patients we put on ECMO, our future projects for our ECMO program, and then we have 2 cases to be presented by 2 of our fellows. So our vision started 4 years ago. We had a vision to build a center of excellence for pediatric respiratory ECMO program at a national level. In order to make this to happen, multiple things had to be addressed. First of all was logistics. We needed a team, we needed manpower. We had to come up with policies and SOPs. We needed to train a number of people in order to get our ECMO running. We had to develop ECMO KPIs and awareness. For logistics, what you need is machines, cannulas, and circuits, which is not always easy, not one size fits all. For machines, we had to keep in mind that we need different oxygenator sizes. We had sizes for neonates, pediatrics, and adults, as children above 15 kilos were considered an adult size for oxygenators. For cannulas, since we had both percutaneous and open and surgical cannulation, we had different cannulas for each type of procedure and each type of cannulation strategy that we decided to do for a patient according to our patient selection. It's very important to know that it takes a village. So building an ECMO program is not a one-person job. It took a whole village to build this program. So who's our team for our ECMO program at our institute? We have 6 ECMO intensivists. We have cannulating physicians. 3 of them are surgeons and 4 are intensivists. And including, we had multidisciplinary team involvement, involving the hematologist, nephrologist, blood bank, and the hematology lab were all involved. Our backbone is our nurses, and we have specialized trained PIC nurses for ECMO monitoring and handling basic complications, troubleshooting, and transportation. 25 nurses trained through ECMO simulation training with at least 100 hours to handle primary ECMO nurse. We had bedside nursing guidelines established for competency and safety for our patients, as well as we had several respiratory therapists, as well as EMSs were trained for handling our ECMO patients. So from there on, we had to start teaching our physicians, our nurses, our RTs, our perfusionists about ECMO and how things are done. So we need to do some extra education and training to get our ECMO up and running. Several events were done for pediatric ECMO team to maintain their knowledge and skills, including 100 staff received ECMO training through our courses to train on handling ECMO. These include nurses, physicians, respiratory therapists, EMS, and nursing educators. We also had ECMO med lab and bedside education. We had ECMO workshops were done about 1 to 2 times per year. We had annual scientific forum with ECMO lectures and sharing success stories. We had case discussions and reviews of KPI and outcomes through our M&M meetings and departmental meetings as well. We had participation in the 2nd cluster data registry for also as international database of all ECMO cases. So this is just a picture of our team during our ECMO courses and ECMO teaching that we have throughout the year for both nurses, physicians, RTs, perfusionists, and anybody who's involved in handling our ECMO patients. So after we have our team ready and up and ready to start our ECMO program, we had to spread awareness. And awareness was not only to healthcare physicians in our hospital, it was all healthcare physicians around the kingdom as well as families. So for our institute, we conducted awareness and lectures to cardiologists, general pediatricians, PICU, nephrologists, and blood bank. We did ECMO cases in different educational events. We conducted multiple scientific days for ECMO team. For our families, we try to educate them. So if their child required ECMO, we try to give them some information before we put their child on ECMO, before getting consent. We have multiple meetings with the family throughout our ECMO runs, as well as we give them pamphlets and booklets that they can read at the comfort of their own. So this is the picture of the booklet that we have that we send out to our families. It's in Arabic and explains everything that they need to know about ECMO, definition, complications, what to expect, and post-decannulation. So our 2nd cluster pediatric ECMO workflow. So what we do is we have a pediatric ECMO service line committee, which works on service expansion and activation and discussion for the required logistic and strategic plan. We have bed management and legibility line for smooth life-saving admissions directly under ECMO services. We have assigned respiratory ECMO beds close to resources areas. And we try to train as many nurses and staff as we can due to the high turnover. So who do we select? What's our patient criteria for selection of ECMO? So this differs from the also criteria as depending on our institutional expertise. So what we do is patients with acute respiratory failure, despite optimized conventional therapies and many others may be considered for ECMO if they meet all the following criteria. These criteria include if they are older than 1 year or have a weight of more than 10 kilograms. They have no comorbidities. Usually we aim for a single organ failure, usually the lungs. And patients who have been mechanically ventilated for less than 7 days on high mechanical vent settings. So if the ECMO referral follows these criteria, we consider them for ECMO at that time. And each patient is case specific. So we did identify early triggers, which also differ from ECMO, from also triggers. These triggers are used to give an early identification of patients who require ECMO to prepare for transport and logistic purposes. So one of the identifications is worsening or difficulty to maintain oxygenation for 4 hours. So rapidly worsening oxygen index or more than 30, a PaO2 or FiO2 ratio of less than 150, or oxygen saturation less than 90 and 100% FiO2. We're worsening or difficult to maintain minute ventilation for 4 hours with a pH of less than 7.30 or a PCO2 of more than 60 millimeters of mercury. Also, patients on high mechanical ventilator settings with inability to maintain gas exchange or worsening for 4 hours. We identify these patients with a plateau pressure of more than 28 on conventional mechanical ventilation. We also identify patients on high frequency with a mean arterial pressure of more than mean airway pressure of more than 25, or evidence of progressive or refractory ventilator-induced barotrauma. So this is a roadmap, just a roadmap to identifying patients who need ECMO. What is the criteria, like I mentioned just a couple of slides ago, and also just to discuss what contraindications are for these patients. I've mentioned them in the previous slides. I won't go over them here as well. So patient has met the criteria. Patient's indicated for ECMO. What next? So next, the physician calls 937, and the 937, they discuss the case with the primary team. And once the primary team has a discussion and they do agree this patient requires ECMO, from then on, a consent is taken for the ECMO team. After the consent has been obtained, ECMO activation is ongoing, and then the referral for pediatric ECMO is started, and the team is deployed. The patient is then cannulated and brought back to our hospital. So our promise is to expand the service that is unique and subspecialized to be accessible beyond the second health cluster in Riyadh. And this is just a roadmap as well to how we initiated our ECMO program. So you can see here, we talked about our ECMO logistics, our ECMO team, our ECMO training, our ECMO policies and SOPs, and our outreach program as well. That's a pulling referral and the retrieval system. So what do we have planned for the future? So we have multiple projects planned for the future. We decided to present 2 of them that are still undergoing right now and not yet launched. So our future project, one of them is the post-extracorporeal membrane oxygenation follow-up in pediatric survivors. And the other one is the continuous kidney replacement therapy in ECMO patients. So this project per se, which is follow-up post-ECMO in pediatric survivals, the objective is to develop and apply institutional guidelines for a multidisciplinary approach for follow-up of children younger than 14 years of age post-ECMO. The goal is to develop a multidisciplinary team approach involving 10 domains. These domains involve the general pediatrician or neonatologist, depending on the patient's age, audiology, behavioral pediatrics, psychologist and psychiatrist, social worker, occupational therapist, physical therapist, dietitian and nutritionist, parent and patient representative, and hematology and thrombosis team to be involved as well. So in order to make this feasible for our patients, not all of our patients are from Riyadh, and most of them are from outside Riyadh. So where are we going to have these follow-ups? So the plan is to have them as one-day appointments, hopefully in the same place. And it can also be hybrid. So the child and parents do not need to fly out to Riyadh. We can have it hybrid over a phone call or a Zoom call just to check up on the child and ask our specific questions. These follow-ups are recommended just before discharge to have a baseline assessment 3 to 6 months after discharge, 1 year, and according to patient requirements then after. So what will we be looking at? We'll be looking at neurological outcomes, medical outcomes, vascular outcomes, psychosocial, and health-related quality of life. How will this be assessed? So we did that through physical assessment, including growth parameters and neurological examination. And different tools will be used and scales will be used according to patient need and age as well. So what's the benefit of this program? So as we know, the ECMO survivor is a unique patient. This program aims to give long-term information for ECMO survivors. And it also improve management as well as quality of life with early detection of abnormalities, which may be subtle as learning difficulties and allow early intervention and a better quality of life and prevent school failures and further difficulties for the child than after. Our second project, which is still under process, is continuous renal replacement therapy implanted in our ECMO machine. So it's a multidisciplinary team approach to integrate CRT within our ECMO circuit, making management of patients with AKI requiring ECMO easier with less HD cath-related complications. So instead of using an HD cath inserted separately for these patients, which might not give us enough real estate for these children, as they'll have central lines, they'll have our cannulas going in. So we'll connect the CRT machine directly through our ECMO, which has been done in different centers, but not yet implemented in our kingdom. So the benefits of this renal replacement therapy integration into our ECMO machine, it's a safe and effective technique that improves fluid balance and increases filter life. It has a greater decline in BUN in comparison to a patient with HD catheter access, and it provides less thrombocytopenia. So this is a collaboration between the ECMO team, the nephrologist, the perfusionist, and the dialysis nurse as well. The objectives of this project is to establish clear guidelines when using the dialysis in relation to ECMO. We want to have one single connection recommendation to avoid errors. We need a prescription as well, and we need to have clear anticoagulation protocol. So where are we in this project right now? So we're done our planning on respiratory reading. Right now we're in the assessment part, and hopefully within the next 6 months we'll start to implement this project and follow up later on after 1 year by the providers. And thank you so much.
Thanks so much, Dr. Hadil, for your nice presentation. That briefed the main arms of starting an ECMO program. So I would leave you to introduce our colleagues to present 2 successful cases that we had them on ECMO.
So we have 2 of our fellows who will be presenting 2 different cases that we had on ECMO over the past couple of months. We'll be starting with Dr. Maram, and then afterwards we'll be starting with Dr. Mohsen. So Dr. Maram, she's our F3 fellow. You can start Dr. Maram when you're ready.
Rose and Saad, can you unmute Dr. Maram, please?
Okay, thank you so much. Okay, may I please share my slide? If the host can let me able to share my slide, I would appreciate.
Saad, you're with us. If you can allow Dr. Maram to share her slides.
Yeah, till now I cannot share my slides.
سعد ممكن تخلي الدكتورة مرام كو هوست إذا ما قدرت إنها تشارك السلايدات. سعد معانا. أستاذ سعد روزالين who's with us.
Yeah, now I can. Thank you. Assalamu alaikum. Thank you for having the opportunity for me to speak on the Saudi Critical Society. So today I'm going to speak about the first successful case presentation having an AVV ECMO. This is Dr. Maram al-Shahrani, Pediatric ICU Fellow in King Fahad Medical City. This presentation has been supervised by Dr. Hadir al-Jubab. So our outlines for today, we will speak about the patient's demographic, the patient's history, the indications for the ECMO for our patients and her selection criteria, what the ECMO type has been used for the patient and the purpose with the duration, the hospital course, the ECMO complication, as well as the post-ECMO rehabilitation. And at the end, we will speak about the patient's condition upon discharge from our hospital. So we had a 13-month-old girl. She's from Saudi Arabia. Her origin is from Al-Jawf, and she's a 9 kg child. The patient, she's known to have a hyperactive airway disease, and she used to be in Ventolin nebulization as needed at home. She's unvaccinated, and she doesn't know to have any allergies. So the history for our patients started on the 9th of August when she started to have respiratory symptoms in form of cough, fever, and respiratory distress. Then afterward, the patient was admitted in a Jog hospital. She required a nasal cannula for almost like 9 days in order to maintain her oxygenation. Then unfortunately, the patient's respiratory condition, it's become worsened in form of increase in the respiratory effort and the hypoxia as well, for which the patient was intubated and started on the mechanical ventilation for a couple of days. Then after that, her oxygenation doesn't improve, and she started to have a refractory hypoxia on the 19th of, on the 14th of August. So the patient started on the high frequency oscillatory ventilation for 2 days almost. Then afterward, the patient was having like a refractory hypoxia. She was having borderline saturations with the high FiO2 requirement. So the team from Al Job Hospital, they decide to activate the ECMO by calling the unified number for the MOH. So the patient was referred on the 19th of August from Maternity and Children's Hospital in Al Job region. So speaking about the situations of the patients on the referral hospital, there she was sedated with the fentanyl and midazolam, and she was paralyzed with the atrachorium. She wasn't required any inotropic support at that time, and she had an echo there, which came to be normal. For the gastroenterology, she was having a normal examination, and she was covered with the meropenem and vancomycin, and all hair cultures that's been taken from the referral hospital were negative. For the respiratory, she was on the high frequency with the SLE 5000 infant ventilator type with the following setting, the MAP of 25, with the FiO2 of 71, and she was maintaining her saturations around 80s. And the delta P, it was 50 with the Hertz of 5. The PaO2 to the FiO2 ratio, it was 59, which is less than 150. And the oxygen index, it was 42.4. And this is the blood gas from the referred hospital. It was following respiratory acidosis with the pH of 7.36 and the CO2 of 81.4. And the PA2 is 41.8 with the bicarb of 41.5. And this is her initial X-ray while she was on the high frequency from the referral hospital. So after the team received the call from Al Job Hospital, they reviewed the case, they discussed the indication, criteria of the patient, if she's having any contraindication, and also they discussed the case with the primary treating physician. Then the decision was made to start the patients on the VV ECMO, and the team, which would involve the physician, nurse, perfusionist, cardiac surgeon, as a standby with the RT and AMS, all the teams were ready for the retrieving of the patients, and the journey were started. And the journey started from Riyadh to Al Job. So the cannulation was done on the 21st of August on the Maternity and Children's Hospital in Al Job. And it was done by the PICU team under ultrasound guided. And the cannula site was confirmed by the ultrasound as well as the X-ray. The patient was peripherally cannulated by using the right internal jugular as a drainage cannula and the right femoral as the re-infusion cannula. If you can see here, this is like a bedside ultrasound being done by the team. This is the right atrium with the IVC. You can see the cannula here, and it was deep a bit, so they tried to adjust the cannula. If you can see here, they pulled it, and they adjust the proper side. And here, this is the X-ray also from the referral hospital. You can see here the right internal jugular cannula, which was meant to be for the drainage cannula, as well as the right femoral, which is meant to be for the re-infusion cannula. So the patient got to the ECMO machine and was retrieved to our hospital, King Fahd Medical City, on the 21st of August by the Medivac, as managing a severe acute respiratory distress syndrome secondary to pneumonia. So what's the indication and the patient selection criteria, particularly for our patient? She was having an acute disease and reversible pulmonary failure, acute respiratory distress syndrome, and it was refractory hypoxia, despite the conventional mechanical ventilation, high frequency with the high setting. And the mechanical ventilation days, it was almost for 5 days. And her age, it was matching our center criteria, around 1 year, and she wasn't have any comorbidities. So the ECMO type for her, it was an veno-venous ECMO, and the purpose of it is a bridge for recovery. And for our patient, she required almost like a 7 days total duration on ECMO. So she was admitted on the pediatric ICU, and she was kept sedated, paralyzed, and ventilated on the VV ECMO. She was sedated with midazolam of 2, morphine of 40, and draconium of 8. She was required a small dose of norepinephrine 0.03 only, and she was started on the heparin infusion as per protocol. The echo was done for the child, and it showed only like a mild tricathode regurg with a dilated collapsible inferior vena cava, and the cannula of the ECMO was reaching the IVCs. Otherwise, it was like a normal ECMO. So this is her initial vital signs in our hospital. It was normal apart from like a mild hypothermia with a temperature of 35.8. And for the oxygen device, she was hooked to the pressure control with the resting mode, with the pressure control of 12, and she was generating tidal volume of 2.7 ml per kg, with the peak of 24, respiratory rate of 20, with the FiO2 of 40, PEEP of 12, and MAP of 16. Apart from the right femoral, which is and the right internal jugular, the ECMO cannulas, she was also having a left femoral, central line, arterial line, and the other tubes she was having endotracheal tube, nasogastric, as well as the Foley's. She was managed with the Lasix infusion, and her target, it was like made by the team on a daily round. And the gastroenterologist, she kept MPO, and she's been provided by the calories through the TPN. She was covered by meropenem and vancomycin from the referral hospital as the tromitin was added. Then after that, the ETT culture showed like an osteotrophomonas, maltophilia, for which the Bactrium was added as well. This is the chest X-ray for the patients on the day of arrival. And this is the ECMO setting. We can see here that the patient have 7 days on the ECMO, with the revolutions per minute ranging from 5,500 to 5,250, and the sweep gas, the highest it was 1,100, and the lowest it was 500 at the day of cannulation, and the flow as well as the FiO2. So as any patients on the ECMO, they will be on a heparin protocol. The first 6 days for the patient, as she was having no bleeding and nothing, she was having under the non-bleeding protocol. And our target, when the patient's on the non-bleeding protocol, the ACT is supposed to be targeted from 180 to 220. On the day 7 of ECMO, the patient was having hematuria, for which the heparin protocol to bleeding protocol. This is the blood gas of the patient. Since the ECMO has been started, there was no ventilation issue with the acceptable blood gas. So other investigations and images done for the patients, the brain ultrasound, it was done and it came to be unremarkable. For the cultures, beside the Stenotrophomonas maltophilia from the endotracheal tube, she was having a positive influenza B as well as adenovirus. For the complications that happen to our patients, it's hematuria, hemolysis, which is manifested, as you can see on the picture, reddish on the urine color, with the RBC showed 3,000 on the urine examination, for which the patient shifted to the heparin bleeding protocol, and the flow of the ECMO, it was decreased. So it's about the other problems that the patients have during her admissions on the ICU. She was having withdrawal symptoms, which is managed later on by the medication. VAP, as we mentioned, hematuria, and it was resolved, as well as the viruses that were isolated from the respiratory panel, which are the influenza B as well as the adenovirus. This is the chest X-ray of the patients at the day of decannulation. We can see that there is better irrigation and more improved the infiltration. So for the hospital course for the patient, after we retrieved the patients on the 21st of August, the patient started on the ECMO for almost like 7 days. After that, she's been decannulated on 27th of August, extubated almost like 3 days after to the NIV, weaned gradually till nasal cannula, then transferred to the ward on the 5th of September. Then thankfully that she's discharged home on the 11th of September. So we can say that the total durations for the management of these patients from retrieval to discharge home around like 20 days. So we can compare the initial X-ray from the referral hospital and the latest X-ray for the patient, and the difference on the aeration and the improvement on the infiltration. Okay, so post-ECMO rehabilitation, what's been done for the child? She had an audiology and came to be normal with the follow-up, and also for the general peds follow-up as she was having hyperactive airway disease. And for her delay on the vaccination, she was having a schedule for the catch-up vaccine. For the discharge medication, she was on fluticasone as well as Ventolin as needed. During her stay, she's been labeled as a swallowing disorder with the silent aspiration based on the perimeal that's done for her during a stay. So she kept on the NGT with the swallowing clinic follow-up as well. Physical therapy assessment and follow-up with the MRI poking. What's about the conditions of the patient's upon discharge? She was doing well, had a good activity on the room air, and she kept on the nasogastric tube for almost like 2 months post-discharge. Then after that, she had her appointment with the swallowing team, and she repeated her swallowing assessment. And now she's having a regular diet apart from the liquids. She used to have it with the thickener. And the family, they were happy and instructed for her condition. So here we can see our patients while she was intubated, ventilated on the ECMO. And this is our patients on the general pediatric ward. The consent's been taken from the parents. So what's the take-home message from our case? That the VV ECMO is a life-saving procedure, was needed for our patient as she was having a refractory hypoxia and acute respiratory distress syndrome secondary to her viral pneumonia. But take in mind that the VV ECMO also is going to carry a high risk and complications from minor to major, like hemolysis, just like what's happened to our patient. This is like an effort done by all the team from the start until the in general pediatrics, with the consultations been happening in between, including the pulmo, infectious disease, even dietitians, physical therapy, occupational therapy. And it's worth when we can see our patients like a couple of days ago playing on the yard with a good condition. Alhamdulillah. Thank you.
Thanks so much, Dr. Maram, for this extraordinary efforts that you put. We can leave the discussions for the end of the second case of presentation, if you don't mind. So, Dr. Hadil, you can introduce the second speaker, please. Thank you.
Thank you so much, Dr. Maram. That was very excellent. Our second speaker is Dr. Mohsen Al-Zamnan. He's our F3 fellow in PAD, and he'll be presenting our second ECMO case that we'll be discussing today. If you're ready, Dr. Mohsen, share your slides and go ahead.
Kindly for the support from Ms. Rose, if you can allow Dr. Mohsen to share his slides, that will be wonderful.
Dr.
Mohsen
Mohsen,
Zamdan.
can you raise your hand, please, Dr. Mohsen?
Yeah, he did already.
Assalamu alaikum. Can you allow me to share, please? Till now, I cannot share.
Maybe meanwhile, until Dr. Mohsen share his slides, do you have 1 or 2 questions maximum for Dr. Maram? Dr. Iman Ahmed, do you have a question to Dr. Maram?
السلام عليكم جميعا.
عليكم السلام والرحمة.
Yeah, sorry. Thank you, Dr. Maram, for this excellent presentation. My question is regarding your setting during your ECMO. Do you prefer specific settings like low ventilatory support? And she's, I think, 15 months. So just wondering how was possible to do the ultrasound, the brain ultrasound in this girl? And if it's not possible, do you go for MRI before discharge? Thank you again.
Yeah, thank you, Dr. Iman. Usually our setting, it will be determined based on the body surface area for each patient and the age as well. And also it's based on the type of the ECMO that you're using. Regarding the ultrasound, she's almost like a 12 months old and it was doable for her. And regarding the last one, the MRI, there was no MRI it's been done for her during her admission. But clinically, she was doing great, but there is like an appointment for the MRI to be done as a follow-up post-ECMO decannulation. I'm not sure.
Thank you, Dr. Iman, for your question. As Dr. Maram mentioned, usually we do resting settings for all patients. We put them on rate of 10 and pressure control of 10 PEEP, anywhere between 8 to 15 titrated. Again, the ventilatory settings are disease tailored. Each case is specific. We thought this patient would just need a few days to pass this acute period, as she has heterogeneous lungs with some lung being or some areas being or looks good. So that's why you see the rate is 20. So it is disease specific. So there are patients who are on like nil pressures, and there are patients on half support or quarter support, but our standard is resting settings. Thank you so much. And without any further delay, Dr. Mohsen Zamnan is joining us. He's a senior pediatric intensive care fellow and supervised again by Dr. Hadil and Dr. Nabil Mashraqi. Thank you, team. Thank you.
So, Assalamu alaikum wa rahmatullah. Good evening. I am Dr. Mohsen Al-Zamnan, pediatric ICU fellow in King Fahd Medical City. It's really my honor to present and to share in the Saudi Critical Care Society, and thank you. I would like to thank the team to allow me for this opportunity. So I'm going to present the second case of our peripheral VV ECMO. My outlines, I'm going to start about patient demographic data, patient history, and preceding symptoms of admission, indications for ECMO, and the selection criteria, ECMO type, purpose, and duration of ECMO, hospital course, post-ECMO rehab, and then the patient condition upon discharge. So the demographic data of the second case, he is almost 17-month-old boy. He's Saudi from Jeddah, and his weight is 12 kg. So he was obviously a healthy child, and he was vaccinated, and he did not have any drug or food allergy, and he wasn't on home medication. So the history of this patient began on 3rd of August when he presented to the Dr. Sulaiman Faqih Hospital in Jeddah with a high-grade fever, lethargy, and signs of septic shock associated with left arm swelling. So he has been admitted to PICU there after resuscitation and the starting of broad-spectrum antibiotics in emergency department. So in the same day, he has been intubated and connected to conventional mechanical ventilation due to hypoxic respiratory failure. In the second day, he shifted to high-frequency oscillatory ventilator due to ventilation failure with picture of ARDS. So the referral hospital was Dr. Sulaiman Faqih Hospital, and the date of referral was 6th of August. So the situation of the patients in the previous hospital or in the referring hospital before connected to ECMO, he was sedated by fentanyl and midazolam. He was initially having a poor perfusion status. However, he did not require inotropic support. And then he was MPO with distended and tense abdomen on Lasix infusion, 0.5 milligram per kg per hour. Infectious part, he was the blood culture, it showed group A streptococcus. It was sensitive to penicillin. So he was on vancomycin, ceftriaxone, and clindamycin as synergetic effect for Streptococcus coverage. So this is these pictures is representing his initial symptoms and initial presentation to the emergency department. He was having diffuse rash all over the body with progressive bluish discoloration of his digits with picture of purpura fulminans. He was having gangrenous left digits, as you see in the picture, and also was having left arm swelling and redness. So respiratory part, he was on high frequency oscillatory ventilation with a setting of MAB 28, FiO2 100% with delta B 60 and Hertz 5. He was, the oxygenation index was almost 30 with SF ratio is almost around 88. The blood gas before cannulation and connected to ECMO, it was showing severe respiratory acidosis with pH 7.03 and BCO2 is 92.6 and bicarbs 24.2 with lactate 1.8. So this is his chest X-ray just before cannulation and connection to ECMO. As you see, picture of ARDS. So as a summary, what we present, so he initially presented to the emergency department with picture of septic shock. He has been resuscitated and intubated in the first day, connected to conventional mechanical ventilation. He failed in form of severe respiratory acidosis and ARDS picture, then shifted to high frequency oscillatory ventilator. He kept on that for almost 2 days, in which ECMO activation was raised at that time. So after our team reviewed the case and discussed it with the primary team and the referring hospital, the decision was made to go for cannulation and to connect him to VV ECMO. So our team started their journey, which was from Riyadh to Jeddah. So the cannulation date was in 6th of August, and it was on Dr. Sulaiman Faqih Hospital in Jeddah. It was done by our team, ultrasound guided, and the cannula sites were confirmed by X-ray and ultrasound. So the patient was hooked to a portable ECMO machine and was taken to King Fahd Medical City on the same day of which was 6th of August. So the problem list upon receiving the patient: toxic shock syndrome, secondary to group A Streptococcus, septic shock, severe septic shock with multi-organ failure, and respiratory failure on requiring high frequency. So what was the indication in this patient and what was the selection criteria? Toxic shock syndrome, secondary to group A Streptococcus, and respiratory failure with picture of ARDS. He was requiring high setting of mechanical ventilation, almost 3 days, and his age was 17 months, and he was having multi-organ failure in form of secondary capillary leak syndrome, acute kidney injury, and DIC picture. So the ECMO type, it was peripheral VV ECMO, and the purpose of ECMO is bridge to recovery, and the ECMO duration was 18 days. The cannulas site, and it was the drain cannula was in the right femoral vein, and the reperfusion cannula it was in the right internal jugular. So what was the hospital course of this patient in our hospital? He was admitted initially to pediatric cardiac ICU, kept sedated, paralyzed, and connected to conventional mechanical ventilation in resting mode, and as well connected to VV ECMO. So he was sedated and paralyzed. He was on heparin infusion as per non-bleeding protocol. The echo showed normal LV function with proper of the cannulas of VV ECMO. And the initial vital signs upon receiving the patient, the blood pressure and pulse temperature autosat, is all within acceptable parameters. Respiratory rate or the ventilator rate was 15. So the vent mode, it was or he was on pressure control, assisted control, pressure control mode. The pressure control was 14 over 10 beep, and the generated tidal volume, it was almost 2.7 ml per kg with peak pressure of 25. The ventilator rate is 15 and FiO2 is 50%. With MAB is 50. So this is the X-ray upon admission and after initiation of PV ECMO. As you see, this is our cannulas, the return and the drain cannulas. It was on the right and internal jugular and right femoral vein. So what was the lines? He was on right femoral drain cannula with size 14 French and right internal jugular reperfusion cannula, and the size was 12 French. Left femoral central line with 3 lumens and right radial arterial line. ATT tube with size 4.5, cuff tube, nasogastric tube, and Foley catheter. So genitourinary, he was having significant generalized edema. He was on Lasix infusion and he kept MBO. He was having tense abdomen, distended tense abdomen, and he was on broad spectrum antibiotics, meropenem, vancomycin, clindamycin, treating the group A streptococcus, and he received also IVIG course. So what was the ECMO setting during the hospital stay? RPM was ranging from 5,000 to 5,500 rounds per minute. The flow was around 80 to 100 ml per kg. And the sweep gas was almost 2 liters. FDO2 100%. The P1, it was ranging from -50 to -70. And P2, which the pre-oxygenator pressure was ranged from 90 to 100. And the post-oxygenator pressure was 60 to 75. The delta B, or the pressure gradient over the oxygenator, was almost in the 30s. The maximum heparin infusion we reached 52 units per kg per hour, and the ACT was ranging. We are following the non-bleeding protocol, which is depends on the ACT, which was ranging from 180 to 220. Antifactor 10, it was ranging from 0.1 to 0.8. So we did, during the hospital course, the problem list of this patient, it's he developed like withdrawal symptoms upon weaning the patient, and as well as resolved toxic shock syndrome with multi-organ failure, as well as left arm osteomyelitis. We did MRI left arm, as he was having, as I mentioned in the initial presentation, he was having left arm swelling with picture of cellulitis. So MRI confirmed that the findings were suggestive of osteomyelitis. And also he underwent for MRI brain just on day 1 post decannulation, and it showed bilateral scattered foci representing intraparenchymal hemorrhage, likely related to the septic emboli or DIC picture. So the decannulation date was on 24th August. He kept on PV ECMO for almost 18 days and extubated almost 4 days after on to NIV, and then we graduated to high flow nasal cannula. On 29th of August, patient shifted to PICU for continuing of withdrawal symptoms management, as well as weaning of the respiratory support, which was high flow nasal cannula. On 3rd of September, he shifted outside PICU to the pediatric ward on low flow nasal cannula, and then discharged after complete of osteomyelitis treatment and antibiotics on 25th of September. So the timelines of hospital course, 6th of August, the patient was retrieved to FMC, and the ECMO was initiated at that time. He kept on ECMO for almost 18 days. And then ECMO decannulation was on 24th of August, extubated shortly afterward to NIV, and then transferred to the ward and discharged home after complete of his antibiotics. So the hospital course was almost 49 days. You can see the chest X-ray upon or just before initiation of PV ECMO and upon discharge home or before discharge home. So what was the post-ECMO follow-up or care? This patient underwent for audiology assessment. It was done twice in patient. However, it wasn't conclusive because of the patient was crying, so he has been booked for audiology assessment as outpatient. We did also vascular assessment post decannulation. There was partial thrombus on the right internal jugular with no complete occlusion, and lower limbs was unremarkable. He given follow-up with the general pediatric as well as the ID team. So we did also follow-up images. As you mentioned, there was like scattered microhemorrhages in the brain representing microemboli. So the MRI was repeated 2 months post-decannulation in October. As outpatient, there was significant interval improvement within the previous finding of intraparenchymal hemorrhages. The MRI of left arm as well repeated, and it showed also interval improvement with remarkable regression in the previously noted collection in the left elbow. What was the patient condition upon discharge from hospital? He was doing well. He has good activity. And he was on room air on nasogastric tube feeding with follow-up swallowing assessment. And the family was happy and instructed about the follow-up as well as the plan of this patient. So what is the take-home message in this case? VV ECMO is having a role in septic shock. However, sometimes such patients need higher flow in which they require central VA ECMO. Thank you for listening.
Thanks so much, Dr. Mahsen, for your great presentation. That's wonderful. So we can open the floor for questions.
Thank you, Dr. Nada, Dr. Ali, Dr. Hadil, and all the colleagues, Dr. Maram, all the colleagues who participated in presenting this is very strong, great program with amazing results. Dr. Nada, I want to ask about the mechanism of, first of all, the awareness. Is there an awareness for this program among all the Ministry of Health and non-Ministry of Health hospitals in form of knowing patients who may need to be referred? And is there any mechanism for referral from peripheries to your center?
Thanks so much, Dr. Aida, for this question. I would say that there is a plan that is already have an agreement from the president of the second healthcare cluster and the stakeholders together with the MOH ECMO director and the retrieval line with agreed policy and guidelines that is under the process. Once the policy is ready, there will be an organized awareness through the Zoom for all the clusters across the peripheral and central regions to cover all areas of the kingdom, together with sharing the policies through the hospital directors. And this work has been going for the past 1.5 years to process it. We're going through, we went through piloting of cases. First of all, it was like random cases reached to our ER or reached to our adult colleagues on their hotline from the ECMO services that we had participated and offered help. Followed by piloting to study the ground and the demands while checking on the patient's data from the number of the cases, the patient who would need the mechanical ventilation and go through the refractory. And it wasn't easy to get all of these solid data. However, we had the official launching that is planned since this late 2023, and therefore we did share in the social communication groups the referral criteria, and we have conducted the series of education to motivate people to call early and to do consultations. But again, the official channel through the professional channel is coming soon through the MOH. We're waiting for the green light. Thank you.
Thank you, Dr. Nada. We hope to see this, inshallah, activated soon. So as we are aware that most of the cases will be actually from the peripheries that you may see a lot. Saad, please unmute all the colleagues who raised their hands for questions.
Again,
We
this
have
program
Dr.
just
Iman.
for just for clarification that the program is active this year, and we do respond to any consultations that is coming through 1937. You just need to ask for pediatric ECMO service, and they will direct you with the process. Thank you.
ممتاز. دكتورة إيمان معانا.
Yes, Assalamu alaikum, Dr. Aida. Thank you very much for this wonderful session. And my question to Dr. Mohsen, this case, I think, was an exception for the criteria. Usually they are requiring to include, retrieval ECMO. I mean, he was having multi-organ dysfunction. Still, he was accepted. And so was this a special case or an exception?
Yes, Doctora. Yes, this patient was having, and we believe that the patient is having, septic shock. So it's like resolved cause. So all the multi-organ failures related to the poor perfusions related in the presentation of the patient. Once the perfusion is improved, then the organ damage definitely will improve. So this patient get benefits, alhamdulillah, and all the presenting initial symptoms like acute kidney injury and the DIC picture, it's improved with the time, and we achieved a good outcome in this case.
Alhamdulillah. One more thing.
There is another factor, Dr. Iman, if you allow me. Many of these cases, they will give us a form that is filled, and we had to work and improve it to fit in pediatrics on the official face. But whoever is giving you information or sharing the photos and videos, sometimes it's not easy to say this is 100% single organ. Or you arrive while the patient is already decompensated, especially sometime with the logistic delay. Some patients wouldn't tolerate some hypoxemia for a few hours. You will find the patient is having multi-organ failure. Oops. Sorry for that. So as the team arrived already, they will do their assessment and evaluation. They will do the consent, and it's the team decision to go for it anyways, or to withhold, or to take the risk. Like, we are expecting to have challenges. Some patients, they might have septic shock or multi-organ failure on arrival, or a bleeding tendency, or even hypoxemia that would lead to bradycardic arrest or arrest. So those scenarios has been studied, and we hope that we will be able to get chance to put or deploy the ECMO on the best survivors, if possible, or the best quality, predicting the outcome. But all the scores that we would use are not really beneficial, and it's case by case. Some we think are not having hope, and we will counsel the parents for that, and others, they do have a hope, yet they would have major complications. So we don't know which is the best. Thank you.
Yeah, I'm saying this because even today in your by Dr. Hadil's presentation, what's her name? The first lecture, she mentioned the criteria, just one organ and failure, not multi-organ. So how can they call? I mean, if we have this input, so we will be reluctant to call if you are demanding to have just one organ failure to call. So
Yeah,
this
true.
is an exception. And one more thing, the scary pictures. He has these septic emboli, and still he had this femoral drainage, or I mean, this the catheter was placed in the right femoral artery. No, sorry, the vein. So is this okay in such cases, or is it better to have one catheter with dual, I mean, in and out?
True. So it's all the team decision who are there for their own assessment, and not to forget that some patients, they will be vasoconstricted with being on vasopressor, so they wouldn't allow you for the best size. Our aim is to fetch the child as possible, as safe, and then we change the catheters, or we manage it on the once they arrive to the hospital safely, if possible. It was heroic action, and I would have put this case under the challenging cases that we would discuss in the next sessions. But again, alhamdulillah, bfadla, and this patient had intact and good, very good results after three first 3 challenging days. Great questions, Dr. Iman. We'll appreciate it. The policy gonna have like very clear guidance. We don't pre-include patients who have mild thrombocytopenia or mild AKI or ALI, which is kind of multi-organ involvement and impairment. But again, feel free to call, and it's the team who gonna discuss it. We tend to have 3 or more to discuss the cases, and the decision will be based on having 2 ECMO experts at least. Thank you.
Thank you, Dr. Nada. Thank you for the great.
Dr. Hakim, you're still with us?
Yes, hello. Hello, everyone. Thank you, Nada and Hedi. Really great milestone in pediatric critical care at a national level. And thank you, Mohsen and Maram, for this presentation. I have 2 questions for you. It's mainly about the challenge and the logistic. The first one is, I noticed in that setting for the high frequency, for both cases, hertz were 5. I'm not sure if this is a type or true. And as you know, in high frequency, when you decrease the high frequency in some infant, you lose the protective strategy for the high frequency. So the question is, for both Hadil and Nada, how you make sure when the patient is really referred to you is it's a true failure in conventional ventilation rather than suboptimal management. We know that in most peripheral hospitals, they don't have qualified intensivists there or RT. So maybe suboptimal management there could contribute to this condition. just optimization of such cases might prevent the need for ECMO. So is there any process in place to optimize this before sending to retrieve such cases? That's the question number one. Question number two, for the future. Now, this is a great program, and you will have your ICU will be flooded with such patients later on. So what strategy do you have for repatriation? You accept patients from Arar, from Qasim, successfully decannulated. What the process to force the patient to go to a regional hospital? How you do this at the national level, knowing that the family might refuse, the other hospital might refuse, and in such case, you will fill up your ICU with decannulated patient from ECMO and preventing admission of the new patient who really need that ECMO. Thank you.
يعطيك العافية دكتور حاكم. Thank you so much for your question. That's a very good question. That's a challenge we face every day with each consultation that we get. So like you did mention, not always treatment is optimized. And sometimes it's more mismanagement than actually requiring ECMO treatment with all the complications of ECMO. We do our best. We try to assess as much as we can. And we try to give suggestions before we go. So if one of us gets a consultation, we go take the patient from head to toe, and we discuss with the team and give recommendation in regards of what's best for the patient right now. Should we prone him? Should we adjust the mechanical vent settings? Should we give him another chance on the conventional or the high frequency? So it's a challenge. We don't always, it's not always clear for us. And if we do consider this patient to be a patient who requires a good ECMO candidate, and it's more or less clear that he will require ECMO, we do fly out there regardless, and we assess him over there as well and decide if he needs to come on cannulated or not. And we've had patients who have come to our healthcare institute and not cannulated afterwards. Hopefully I've answered your first question, Dr. Hakim.
I may take the second question, Dr. Hakim. This is a wonderful question that we had the challenge to start the program for the past 1 year or more. And the aim is not to hold all the population across the kingdom. We're sure that many of colleagues are working to start respiratory ECMO, or they do have the service, but for one reason or another, they would be part of connecting network of multiple of having a few ECMO centers whenever it's needed, to have more than one area to fit all. We were promised, and we do appreciate the support from the administration at administrative institutional level, at Ministry of Health level. And again, the reason of launching it this time is because we've been too long waiting, and there is some demand. We do offer the service. We are tertiary center. We don't have a good patient who fit the ECMO. Out of 50 consultation, I would have one patient on ECMO from my hospital population, because we're tertiary, we're receiving oncology, severe immune deficiency, and different type of patient that could be late. So the best is to give this service for population who would need it, healthy otherwise, and they require it, especially the secondary health centers, where they have high load of community-acquired pneumonia and ARDS with kids healthy otherwise. So again, we're going with that, with this slowly. As you see, it's very restrictive criteria, and it is respiratory based for pediatrics. It did not include neonates. It did not include cardiopulmonary. It did not include isolated cardiac. As the service is available in-house, but not for out-house. So we will do this slowly, and as there are some centers joining sooner or later, we will be able to expand slowly or study the ground on cases, case by case. I can tell you, like, every single consult is a challenge, and we do have interventionist cardiologist and cardiovascular surgeon with us in the committee, and this is just to assess the need and the demand, and whenever it's feasible and doable without creating high load to serve the the most vulnerable patient that a tertiary center would need to help with, we will be able to serve remotely بإذن الله. Any other questions? Yes, please. You are unmuted.
السلام عليكم.
عليكم السلام ورحمة.
يعطيكم العافية. This is Dr. Saleh Shehri from KSMC Cluster 1, Riyadh. Thank you, Dr. Nada, for bringing up this interesting topic, and thank you for your team for the collective case presentation tonight. And without discussion of the the cases of the ECMO, the troubleshooting, the task, I'm just focused trying to think about the big picture, as Dr. Hakim mentioned. Now we are in the winter crisis, and last year winter crisis was worse than this year. And this year still we have the same high flow but less intensity. If you agree as a whole, higher centers, I need your reflection on this. The same pathology that you're bringing tonight, like the respiratory viruses, adenovirus, and the group A streptococcal disease, a well-known re-emerging disease after the pandemic COVID-19. I'm just trying to think about like the equity and competition on the resources. Like last year, we had a lot of cases with the similar presentation, but I will think of ECMO. I will send you like 5 maybe per month cases. But I'm talking about extraordinary selection of criteria. If we talk about the crisis during the winter, I won't do any cannulation for such cases, except what we have done because this patient is outside Riyadh and they don't have the proper facility to manage with a very good set of ICU and maybe late intervention from higher center, so they might go for ECMO as exceptional. But we are trying to think about how to modify the criteria to select special respiratory cases where we have only like in the MOH, your center who is doing now the ECMO. So if you want to do ultra selection based on the calls that you are receiving through the 1937, what do you think the cases we should agree on to select? Thank you.
Dr. Saleh, if I did not misunderstand your question, you're asking what are the best cases to select for ECMO deployment? So what are the best cases?
Yes,
Or
Dr. Nada, considering our national program, and we want to focus about our national program. If I don't want the junior colleagues of ICU fellows or even junior colleagues of consultant, they will think about this all cases, such case should be treated as ECMO, because we are treating such cases without ECMO in the tertiary center. My question is, do we need to revise our respiratory cases ECMO criteria while we are discussing the respiratory cases? Because there is a lot of like cases that we can think about cannulating them. But if I want to look to see my patient, they fit all ECMO. But at the end, it's very difficult to consider ECMO for all of these cases. From your experience, now you are leading the call centers of 1937 for the ECMO. What do you think? Give us like very narrow window of respiratory cases that we should agreed on as criteria to start sending to you.
I got you. So, Dr. Saleh, as you know, dealing with remote areas is very challenging with the available logistic to reach the hospitals on time. And you guys mentioned that lacking experience of intensivist, and I believe that tele-hospital ICU and tele-ICU would have helped to minimize with the collaborations that we would have in the near future to work on it for the best choice of the patients. Now, there are triggers. So my colleagues didn't, like we had before sent triggers, but those are triggers to call, not necessarily to put on ECMO. So we go with pediatric ARDS criteria. If you are in-house, we wouldn't put a patient with pH less than 7.2 or maybe 7.15 even. We wouldn't put a patient with CO2 less than 80 or 100. Like, we take high numbers on our own population inside the center. We take the high frequency as a mode of a bridge to recovery and survivors, unlike the adult colleagues. And even when we go there, we test the patient on our mechanical ventilatory support and our own ventilation to assess the compliance of the lungs and the ventilatory to exclude the ventilatory failure or lack of the equipment's support in some peripheral hospital. And this is what Dr. Hadil, like, we brought 2 patients with backup ECMO support, and we took the risk to transport a patient without ECMO, just to save him from the amount of complications and comorbidities that could be associated with ECMO. So the criteria that we put in the policy is not a one-man or one-center show. It was a contribution of work of multiple champions who have the ECMO experience across the kingdom. I do have, I'm certain that many of you are expert and you have the experience, but people who were motivated to open the program, chosen by the MOH director, and we had met as pediatric intensivists from different areas to put these criteria. So it's not solo KFMC criteria. Now, when someone referred to me, sometimes the desaturation was going on at 40 for 6 hours. I cannot reach this patient if he is far away, and he might be 85, is still acceptable. And we say, well, it's accepted, go on, fine tuning, but we closely monitor those patients, and we make sure that either ECMO is needed, depend on the disease pathology and the settings that he's on, and optimization, fluid overload, like many other considerations are taken. We wouldn't be perfect. There will be there will be gaps, there will be drops in between. We will be attending a patient who is off sedation where we are trying to cannulate and he's brain dead. We will be approaching a patient that once we put a cannula, he arrested because of a borderline situation. We will be cannulating enterovirus as VV ECMO, but he has yet developed myocarditis with cardiac arrest. Like, things like this we have faced in Canada all the time, or anywhere in the other hospitals. So I wouldn't think I hope that whatever criteria we put is the best based on the probabilities and the group thinking. However, there will be always fine tuning and changing to the policy and the group, and any suggestions will be very welcomed to improve the service, because this service is not for us. The service is not for our children only. The service should serve any healthy child otherwise across the kingdom. And we do have difficult cases where we need to consult experts from outside, or on difficult night, and we will call people from London or USA or etc. Like, it's not simple. We understand our limitations, and we hope that we will improve together, and you will help us to improve the service. أعتذر على الإطالة, and I hope I answered your question.
دكتور مصطفى معانا. We'll take the last question because of the time.
تمام، الله يعطيكم العافية جميعا. It's not a question other than comment. So just to emphasize on a point, the criteria when it was selected and chosen, it being selected to be as early as possible. So when we say the single organ failure respiratory, that to avoid the call when the patient having hypoxia, bad enough to affect another organs or hemodynamics, and we end up with like multiple inotropes, brain ischemia, seizure, and that patient will be not a candidate. Each case will be discussed and based on the distance of the case, based on the place of the case, the agreement to put the patient on ECMO or to move towards center with ECMO will be taken. So most of our triggers are early triggers, and that to motivate the people in the centers just to call in on early basis rather than to delay. That doesn't mean all patients who fit these triggers will be put on ECMO by the end. So initially the call will be received, discussion with the treating team. Even when we receive the call from the treating team, we understand what their limitation, how the center is supported, who is treating this patient in that center, and the decision to put ECMO or to have the ECMO retrieval team going to that center is based on all of these, based on logistics, distance, what kind of support the patient have, what management already provided. We give also our recommendation as a medical recommendation, not ECMO at the beginning. So we tried our best with medical management, if that a chance, but if also the acuity, the severity of the illness, all of these are factors. So why we put the trigger as very limited trigger or very early trigger that to induce early calls and to have a better outcome and better like selection of the cases. Definitely when we have a brain insulted, when we have heart insulted, these are the main two organs. When they are affected, the decline of ECMO support will be high. And that's why we don't want to have the calls with the respiratory support with a patient who is on epinephrine of 1 and norepinephrine of 1, because that means he needs VA ECMO, which is not in our retrieval criteria. We don't want patient who is already hypoxic on 40 saturation for 2 days. We don't want also the patient who arrested because of hypoxia and then he recovered, then he's on high frequency, and then we receive the call. That's why we put the one organ selection, and then the modification will be based on multiple factors. When you tell me that patient is hypoxic with some sepsis, but still he's holding hemodynamics, still the acute kidney injury only related to some fluid overload, so to the early sepsis, we consider him for support still. That's why we put a general early selection criteria, which is the safest to have early calls rather than to receive a late calls.